If you're looking after a patient with an epidural, then this might come in useful. So I'll talk about what an epidural is, how it's different from a spinal, and why the difference is important, particularly with regards to obstetric anaesthetics. So you probably know that in your spinal canal, you've got your spinal cord, which supplies all the nerves from your body up to your brain. But the spinal cord ends at about the level of L1, which is sort of your lower rib cage at the back. Below this, the nerves that are in the spinal canal are like al dente spaghetti. And the idea is if you put a needle anywhere near the spine, you want to do it lower than the level where the spinal cord ends, because if you touch one of these little nerves with a needle, the chances are it's just going to move out the way and you're not going to do any damage. And any needle going anywhere near the spinal canal is usually blunt to reduce any damage as well. You're doing it below the level of L1, and we generally say below L3 to be extra safe. So any procedure involving the spinal canal is deemed safe if it is below the level of L3. That's why we go there. You can do an epidural at any level. You can do a spinal technically at any level. It's just riskier the higher up you go because the spinal cord is solid, and if you hit the spinal cord, you're more likely to do damage than if you just hit one of those floating nerves that's at the bottom. So the spinal cord runs up the middle of your spinal canal. It's swimming in CSF or cerebrospinal fluid, and that is all wrapped in shrink wrap called the meninges. And those are what get inflamed in meningitis. And the outer layer of the meninges is called the dura. That's why it's called an epidural, is because it's outside the dura. So a spinal anesthetic, you go through the dura into the CSF and you put your drug directly into the cerebrospinal fluid. That's why when we put the spinal needle in, we check to see that there's CSF coming out the needle, and then we give our injection. If we're doing an epidural, you don't want to puncture the dura, you want to stay outside or epi the dura. So what you're trying to do is you're trying to get the catheter for your epidural to sit just outside the dura. Now, if you're coming in from the back of the spine, you're going through the skin, which you've hopefully numbed with some local anaesthetic, and then you're pushing your needle through the ligaments between the bones. Now, those ligaments don't have any nerves. It's not comfortable, but if you've given lots of local anaesthetic, most people aren't bothered by it too much. There's the last ligament before you get to the dura, which is the ligamentum flavum, which is a really strong ligament, and it stabilizes the spine. Now, the epidural space is what we call a potential space. This means that the dura and the ligament will be right next to each other, and it's got some veins and a little bit of fat in that space, but it's not a big space. So it's quite hard to land the end of your needle in it. So what we do is a loss of resistance technique, which is why we use those weird blue or green syringes. These syringes have really loose plungers, and the idea is if you are inserting a needle and pushing the needle, then when you go through the ligament, you'll lose the resistance, but you will push the needle likely through the dura as well. But if you're pushing on the back of the plunger, which has got fluid in it, the second the tip of the needle goes through that ligament, there will be a loss of resistance to the fluid, and your thumb or your hand will just push the plunger in. So that's why you see us breathe a sigh of relief as junior anaesthetist when you see our hand finally go, because that loss of resistance means the needle has entered the epidural space and all that fluid has just pushed into the epidural space and hopefully opened it up nicely so we can get the catheter in. We will then take the syringe off and we will look to check that there's not CSF coming back, because if there's CSF coming back, that's a dural tap. We've accidentally punctured the dura. You'd have to redo the procedure at this point. But assuming you haven't got CSF coming back and you've had that nice loss of resistance, then you can thread the catheter in, safe in the knowledge that it's going into the epidural space. You then might see us lift the catheter up, and the idea is the catheter's full of fluid, and if it's a potential space, then the fluid will drop and you'll see us watch the little meniscus drop. If it doesn't drop, then that's a suggestion that you've not put the catheter into the right space. So all of these steps are just reassuring you that you've put it in the right place. Then we'll put the filter on and the clamp, and then at that point some of us will give a test dose. So if you give a small dose, it allows you to check the response before then giving a bigger dose and causing potential problems. So you put the syringe on and you aspirate first, and you check to see that there's no blood or CSF coming back up your catheter. If you've put it into the epidural space, there's a chance you could have pushed it into an epidural vein. So if you get blood coming back up, you need to readjust where the catheter is. But assuming nothing comes back, you can inject your test dose and finish dressing the catheter. By the time you've finished and you've plugged them into the machine and got that all set up, by that point you should notice if there were any significant problems. So if you'd put the catheter into the spinal space and somehow that hadn't shown up, you hadn't got any CSF, but somehow the catheter was in the spinal space, the patient would have quite a dense motor block. They wouldn't be able to move their feet. So you might see us give that dose, finish dressing, plug the machine in, and then get the patient to move their feet. That's because we're testing for a motor block. If they don't have a motor block, that's reassuring that you've got the catheter in the right space, in the epidural space. If they do have a motor block, there's a chance that that catheter is now in the spinal space, basically needs to come out. So these are the key things. The key differences between an epidural and a spinal are your dose. You're very often giving the same drug, sort of combinations of local anesthetic like levobupivacaine, ropivacaine, lidocaine, and then an opioid, so fentanyl, diamorphine, morphine. But you're giving very different doses. So you can give sort of 10 to 20 mil boluses through an epidural, and that will give you nice analgesia. But if you gave that spinally, you would give them a total spinal, so that would anesthetize the whole spinal cord and the patient would go unconscious, and then you have to manage that as well. It's a manageable situation, it's just not a good situation. So the idea is you're giving tiny doses for a spinal. You'll see when we do a spinal anesthetic, you're injecting 2 to 3 milliliters of the same drugs, but they're much smaller doses because it's directly into the spinal space. It's much more potent. Whereas the epidural space, because it's outside the dura, put in much bigger volumes and it has a much gentler effect. So the key points are: a spinal, you want to see CSF and you're giving a small dose into the spinal space where the fluid is, and you're doing it below the level of where the spinal cord ends because it's much safer, because the spinal cord has finished and it's just loose nerves that will move out the way if you put your needle in there. And an epidural, you are one layer shy of going into the cerebrospinal fluid. You are outside the dura, and that's why you can safely put a catheter and give bigger doses and bigger infusions, because you're further away from the spinal cord. Now, the reason we use the cold spray to test is because the spinal pain and temperature tracts go together. So they're on other sides of the spinal cord to fine touch and vibration. So we test with cold because we know if cold is blocked, then pain's blocked, but fine touch and vibration aren't necessarily blocked. If you do a spinal, you tend to anesthetize everything, so they'll get a motor block, they won't be able to feel fine touch or anything really. But with an epidural, often you can successfully block the pain pathways and the cold pathways, but not block the motor, so they can still move their legs. So that's why we use the cold spray, and it's pretty good because you can literally spray it up the body and it will give you a level, a dermatomal level of how high the block is. And we're aiming sort of, depending on whether you're going for analgesia or cesarean section anesthesia, we say between sort of T8 to T4 is our sort of where we're aiming for.